So the first thing you want to do is just have the patient lie on his back. If you want to put his head up a little bit, he can. If the patient wants to watch, it's not a problem. If they don't want to watch, it's not a problem. They have an option to watch the screen alone or just watch nothing. Our patient here has decided he doesn't want to watch anything, just wants to relax, so he's lying flat on his back with his head on the pillow. And so what I want to do is have his legs straight and feel the inferior pull of the patella, okay, and mark that. So I'll put a mark on the inferior pull. If you feel off to the side, you're going to see a soft spot below the patella. That's where your poke holes, you want them to be. If we measure this, it's about a centimeter down and across. So about right there, and about a centimeter and a half to 2 centimeters on the medial side. Now the interesting thing here is when we go from these poke holes, we're going to be able to see all sides of the knee. If I come here, I'll get a good shot of the medial side, the ACL, and then the lateral side. If I go from the medial aspect, I can see the same thing, but I see the ACL origin a little bit better. We tend to like to go lateral just because that's what we're used to doing in the operating room. So after we mark them, the next thing we're going to do is sterilize the area that we're going to go into. Now, oftentimes we'll go superior laterally. We'll sterilize this as well if we need to see the patellofemoral joint. And then once we do that, we will inject. We often will spray just to help a little bit of the pain. This is just regular, 0.5% Lido with epi. Now a little bit of stick, Jason. So a little stick, and we just want to numb this up. Now make a nice wheel in the skin, and then we go down, and you're going to feel a little bit of discomfort as we get to the fat pad. Now, some doctors like to use this needle to sound in the joint so they can figure out where they are, and that's fine. I'll often go to this side as well, and it's that initial stick that hurts and burns. I'll put a little bit in the fat pad, but not a lot in the joint. If you put too much in the joint, then you're going to have difficulty seeing. And then we just relax. An alternative way of doing this, and how I used to do it, is have the patient seated. One of the advantages of this, we used to think, is that there would be some gravity distraction of the knee joint. But the knee's at 90 degrees, and oftentimes this makes it a little difficult to see the posterior aspect of the meniscus. And if you think of it in the operating room, we usually don't scope the meniscus at 90 degrees. It's great for the ACL, but not for the meniscus. It's comfortable for the patient because they can sit there, lean back if they want. They can even lie flat and do it this way. You can also add a valgus moment on the leg to open up the medial compartment by taking your lower leg and pushing it this way. Then you can put a varus moment by just taking it this way. So it opens up the lateral compartment or the medial compartment. It allows you to flex the knee, but it's very difficult from here to get extension. You can't do it. And while this will work, I think it's advantageous to have the patient lying flat and keeping the leg straight to 30 degrees because that's where you do most of your meniscal arthroscopy. So after we do the injection, what is the optimal time to wait to do the procedure? I usually end up waiting between 5 and 10 minutes because I'll usually inject the patient, let them relax, go see another patient, and then I'm ready to go. When I come back, you'll often see what we see here. You'll see the white blanching caused by the epinephrine. So then I know that that's taken effect. We have decreased blood flow. Most likely the lidocaine is now taking full effect and he's not going to feel anything. So we'll take a look and make sure we're able to see and we have a good picture. And then we retract it and we're ready to go. Now my right hand is my sterile hand, and we're going to go, just let your patient know what you're doing. And then once you get in, we can kind of feel where we are. And then take your time when you get here. So now there we go. We know we're in the compartment. We can see there's his medial compartment. There's some stuff on the outside here, and he's had a previous meniscectomy. Put a little bit of fluid in the knee, and catching the notch often is helpful. If I take his knee and I cut it down about 30 degrees, then I can get his medial compartment pretty nicely. Jason, how you feeling?
No, fine.
You're not having any pain?
No.
If your assistant, sometimes will put a little bit of a force on, could be helpful. We're going to go to his lateral compartment, and to do this, what I can do is just take his leg and push down a little bit. So we're good. So there's his ACL. You'll see it right there. Nice picture of his ACL. It looks good. I can go over to the lateral side. I'm seeing the ACL scar, and now I'm getting over the lateral side of his knee. And take your time when you get here. Little movements will allow you to see things better. And we're getting his lateral compartment. So we're in your lateral compartment now there, Jason.
Okay.
Your condyle looks pretty good. I'm going to bend your knee a little more. Crank that open. Now I'm in your lateral compartment. You can see a little bit of arthritis right there. So we have some grade 2 to 3 changes on the outside of your knee, and that's more arthritic change, not overall. And then we'll see your meniscus right here. So there's your meniscus. You see a really good picture of your meniscus there. Now you see we're having a little trouble seeing this posterior horn right there. If I just put a little more, a little bit of force on there, he's got that debris in there. Just relax your leg. There we go. And once we get in here, so we have wear, and you can see that chondrosis right there. So you got a fair amount of arthritis there, Jason, on the lateral aspect of your knee.
Mm-hmm.
Your meniscus is in pretty good shape in the front. Okay. And then back to your ACL, you get a really good picture of your ACL there. ACL's attack looks good. Your medial side. Now we'll suck some of this fluid out. There's where you had a meniscectomy. Did they fix your meniscus, Jason, or did they take it out?
They probably took it out. It was 30. Well, it was a long time ago. 20 something.
Put your hand there, please, Regina. So you see we get a pretty good look at his meniscus coming from this direction. Lift that up. Oh, yeah. See we in the back. Your medial meniscus actually looks pretty damn good. You know, it looks like what they did before worked. You have, you know, it looks like there's where your meniscus. You have a little bit of meniscal tearing, but medial, you're doing well pain-wise.
That's where I think that's where my pain is.
On the outside, though.
Medial, yeah, mine's
Yeah,
lateral.
sorry.
That's correct.
So you can see how he really good picture there. He looks really good. His medial side looks really, really good, which is surprising. And then if we pull back a little bit, there's his ACL. Again, we get a little bit of blood in the field. That looks good. And then laterally, So you see is that little bit of cartilage change. And there's this, and now you can see why he's having pain. So Jason, if you look right now as your knee's bent, there it goes from normal. That's big time condyle defect right there. I'm going to blow some water at it. So you're wearing out on that part of your knee. So if we bend you more, you can check his whole femoral condyle, and you guys can see that cartilage defect. Now that's a big flap of cartilage, and you guys, we can get a nice picture of that.
That's where my pain is.
Well, that's where your catching's coming from. Your pain is for that. So you have the option of going in and debriding that. Okay, and then when we're done, what I like to do is I like to suck as much water as I can out, and sometimes you can get more and sometimes you can't. Sometimes it's easier to suck water out with the scope pulled back, and then once you finish, we just pull out. Put this, because he is going to drain a little bit, and you can see he had, no pain, and that took, we probably were in there 5 or 6 minutes. He did fine, and we got what we needed to do.